Okay, good morning again. So this is a little bit like getting the band back together for me. It's just wonderful to sit here and see so many familiar faces and to share the stage with all three of these individuals. In February of 2024, something very, very important happened. At least I consider it very significant. Birmingham, Jefferson County, JCDH, the Recovery Resource Center, we had a very special visitor. Her name was Dr. Mandy Cohen, and she was the director of the CDC. She came with her team to sort of see what was happening in Jefferson County. Since 2019, the CDC's administered a grant called Overdose Data to Action. And she wanted to come and see some grantees who were making a very significant impact. What she saw and heard that day was the result of a lot of the things we're going to talk about today. It was a result of collaboration and dedication and a focused public health approach to this overdose crisis. This morning we'll hear from three individuals who are very central to that effort, and you can all sort of briefly introduce yourselves.
I guess I'm first.
Mm-hmm.
Can you hear me?
Did you turn it on?
Maybe I need to turn it on.
Top.
Okay. How about now? It was on.
Yours is
Sorry,
different
y'all.
than mine.
Volume. I can talk loud.
I guess while they're working that out, I'll go ahead and
There
introduce
you go.
myself. I'm Alan Treadaway. I retired as Assistant Police Chief City of Birmingham after 31 years, and this is my 20th year in the Alabama Legislature. I represent District 51, which is north of Birmingham, Gardendale to the Blount County line.
All right, now I'll go. Hi, I'm Dr. Mark Wilson. I am the former Jefferson County Health Officer. I served there from 2011 to 2023. As health officer, that also means that I was the head of the Jefferson County Department of Health. I currently work at Baptist Princeton Hospital on inpatient medicine service with their residency training program.
Good morning. I'm Darlene Traffenstead. I'm an internal medicine physician by training. I've practiced for about 14 years here in the Birmingham area. I was elected to the Alabama Board of Medical Examiners in 2013, and that's the physician regulatory body in the state. So that body is responsible for regulating physician practice and prescribing. And so that was actually ultimately what led me into a career in public health, where I worked for Dr. Wilson beginning in 2018 and just recently transferred over to Alabama Medicaid to work as their medical director.
Okay, so we heard a little bit about the numbers earlier, but I'll talk about 2010. There were 12 heroin-related overdoses in Jefferson County that year. In 2011, that number jumped to 24. By 2012, it was 124. So that was definitely an exponential increase. The three of you played a very significant role in sort of what happened next. Dr. Wilson, can you talk a little bit about, it was 2013, I believe, there was an op-ed in the Birmingham News. You were already paying close attention to this, but this op-ed sort of set in motion a chain of events.
Yeah, I actually wasn't paying as close attention to it as I should have. I wasn't completely aware of the gravity of the situation as health officer. And we didn't always have the best access to data at that time. But I'll start by just saying I was in the Leadership Birmingham class of 2013. And one of my classmates was then U.S. Attorney of the Northern District of Alabama, or the North Alabama District, Joyce Vance. And on one of our bus rides on a field trip, she sat next to me and said, we've got a big problem and we can't arrest our way out of this problem. We need to partner with you in public health to take a multidisciplinary approach to address this. At about the same time, she did write an op-ed in the Birmingham News, and I've got the title of it here. It was titled "Community Action Needed community action needed as heroin deaths rapidly climb. And in that article, a couple quotes. One was, "This is not your grandma's heroin. This is highly pure and very deadly." She cited the increasing numbers that you've heard. And then she said this, "The demographic for heroin use is your children. This is not somebody else's problem. The reality is that this is a highly addictive drug, and it's sweeping through 17 to 25-year-olds at an alarming rate. And it is as likely to happen in your straight-A student or your football player as it is a child that you might have thought of as being a more likely user. The path to addiction is prescription drugs." And so soon after that conversation, we had a meeting at the U.S. Attorney's Office, myself, Joyce Vance, Max Michael, who was then Dean of the School of Public Health at UAB, and Foster Cook, who was with the Community Justice Programs at UAB's Substance Abuse Department in psychiatry. And Joyce said that she wanted to pull together a summit from multiple stakeholders in the community. And so we sort of scrambled around and did that, and we had what was called the Pills to Needles Summit at UAB in June of 2014. Over 200 people attended. We had representatives from law enforcement, public health, academia, education, people in recovery, families of people with addiction, including people who had died from overdose, and many others. And at the end of that day-long conference, we had a lot of audience input on how we should address this problem. 2 months later, we followed that up with a strategic planning session with 50-some-odd stakeholders and came up with basically the framework of a community-wide strategic plan. Some of the parts of that community plan were public awareness, because a lot of people didn't know this was a problem at the time, access to treatment, continued law enforcement efforts, not focusing on people with addiction as much as the traffickers, outreach to the prescribers, the medical community, and then the area of research and policy. So one of the early wins that I'll just mention, a couple early wins. One is we did engage a lot of people, including those who are in recovery, to do the community outreach, the messaging to the community, multiple forums. But one of the great early wins was passage of the legislation that made it possible for laypersons to carry naloxone or Narcan, which was then a prescription drug, which somebody cannot administer to another person without a medical license or being a medical professional. And also for law enforcement to be able to carry it, because sometimes they were the first responder on the scene of an overdose. And that bill also provided immunity to those who prescribed it or administered it, and also immunity for people that were like that person that's there at the scene using drugs also, that they would not get arrested if they called 911. I think that might be a nice segue.
Absolutely. Representative Treadway, you played a major role in that legislation, but you also had a personal experience around 2014, a friend whose family was affected by substance use. Can you share that story and then how that led to you sponsoring the naloxone bill?
Right. So the first time I ever heard about Narcan actually came from a doctor of dentistry, a friend of mine that lives in Mountain Brook, and it was his son. He brought it to me, and he said, "This is something you need to look at." I had no idea. I've been on the scenes of enough folks dying, especially overdosing, and the medics in Birmingham show up, and they're either on time or they're not. So it seemed like a good concept to me, but I was kind of, how does this happen to somebody in Mountain Brook from such a nice family? But that's about that time Dr. Wilson got involved, and I need to publicly give him a lot of credit for what you did, because you educated me, you brought stats to me, and we started that process of getting the legislation ready. And we ran into a lot of problems. There was a stigma about we're just prolonging this, folks are not getting over heroin, it's a 2 or 3% recovery, And then the other was the immunity part, and it was necessary. But in my own profession, there was a lot in the law enforcement community did not want to give immunity to anybody that was on the scene that may have drugs and in their possession. So we had to work through all of that. And the other, to be honest, I said, how many states have this? So about half the country at the time, and I'm thinking, well, this is Alabama, so we're looking at, we're trying to really push something early, aren't we? Because we're about the 49th or 50th state. But with PARCA, the stats, the push, the lobbying, it all came together, and we were able to get the legislation enacted. So it has saved lives. There's no question about it. I got a thing, one of the best correspondence I ever got was from a deputy, rural deputy sheriff. And he said, if you ever thought what you do in Montgomery saves lives, or he said, let me share something with you. And it was a local newspaper where a child had gotten into some drugs and was in respiratory failure, and he had Narcan on him. And he was able to save that child. And man, if that doesn't touch you, I don't know what does. And it really made me proud. And again, thank you, because without you, would not have been in that. Just because it was brought into my world by a friend, I really didn't know where it was going until what was happening here in Jefferson County and Dr. Wilson and pushing it.
Thank you. Dr. Travenstadt, Dr. Wilson a lot of times said you came onto the scene and you added rocket fuel to the response. You talked a little bit about serving on the Board of Medical Examiners. From that vantage point, can you talk about how you saw an opportunity to work on the infrastructure, both at the county and state level, to sort of address this epidemic?
Sure. So I mentioned that I was elected to the Alabama Board of Medical Examiners in 2013. And as you saw earlier, in 2012 is when Alabama peaked in its opioid prescribing. Very excessive amounts of opioid prescribing, and we were obviously the #1 state in the country. So as I came on to the Board of Medical Examiners, we were very focused on curbing overprescribing of opioids in the state. And we did. And we took appropriate action against physicians and other healthcare professionals who were overprescribing opioids. But as I was watching that happen and realizing that we were pulling a lever that we had to pull at the time, I was also watching that overdose rate grow. So what I realized was, especially in some of these more rural areas, is that these physicians were the sources of the opioids. And they may have lost their license to practice, they may have lost their ability to prescribe controlled substances, or in some cases they were, held accountable by the criminal justice system. And so when those prescription opioids went away, in many cases individuals had opioid dependence, and opioid withdrawal is brutal. It's very, very miserable situation. And so we saw that, switch over to illicit opioids, which then, caused the overdose rate to increase. And so watching levers being pulled and watching the results of those levers, and then trying to say, okay, this is, our system is not set up at this time to meet the needs of these individuals that are here that have opioid dependence. We don't have the substance use, assessment and treatment capacity that we need. We don't have the overdose prevention resources in place. And we, as a state, have to come together and do something about that. Around that time, Governor Bentley actually established a healthcare improvement task force, and I was on that task force, and an individual from the Alabama Department of Mental Health was on that task force by the name of Sarah Harkless. She ran the substance use treatment. She was a part of the substance use treatment services at the time, and she was shouting from the rooftops, people are dying, we have to do something. And out of that group came the first statewide opioid summit in 2017, and it was called From Silos to Solutions. And that's where we really got everybody together in the state and really got out of our silos and started, collectively problem solving. And really that was, for me, what ultimately became my desire to move over and work on this full time and leave private practice. And Dr. Wilson had obviously shown tremendous leadership in this space. and I moved over to work at the Jefferson County Department of Health with him on this crisis.
So I mentioned the OD2A, or the Overdose Data to Action Grant. So it's central to a lot of this work, not just for Jefferson County Department of Health, but also for the Alabama Department of Mental Health and Alabama Department of Public Health. Can you briefly describe that and maybe touch on the Overdose Task Force when we saw the heat map that really brought back some memories there, and the first time we started seeing that? And then also maybe the naloxone, this is a lot, maybe the naloxone saturation in the mail order that Stacy referenced.
Yeah, so it's a lot. So, remind me if I forget to touch on something. Obviously this crisis was happening across the country, and the federal government began establishing grant programs. There were grants that flowed through to the Alabama Department of Mental Health, and there were grants that flowed through on the public health side to the Alabama Department of Public Health. Data-Driven Prevention Initiative was the first one, and then that was followed by the Overdose Data to Action Grant, which was started in August of 2019. We were fortunate enough to be a subrecipient of the ADPH grant and worked extremely closely with ADPH and ADMH on all of our initiatives. It was a tremendous state-county government partnership there. So OD2A, Overdose Data to Action, had a surveillance side and a prevention side, and the goal of that grant was to use overdose surveillance to drive prevention activities. So if we took an action under that grant, it had to be a data-driven action, right? We were developing the ability to monitor overdoses in real time. If somebody went to the emergency department for an overdose, we knew within the next day. If somebody had an EMS run for an overdose, we knew the same day. Our colleagues at the Jefferson County Coroner Medical Examiner's Office gave us a report every day of the suspected overdoses that they had worked the previous 24 hours. And so what we were doing, we were building these heat maps, and then our team of amazing public health professionals, public health nurses, we had college students as interns, and as soon as we would see a hot spot pop up, we mobilized along with our partners at Addiction Prevention Coalition and Recovery Resource Center. We mobilized to that zip code, neighborhood, street, city park, and we talked to the people that were there, and they told us what was happening, and then we were able to meet their needs. We were able to bring naloxone to them, or fentanyl test strips once those became, legal. So we were able to in real time address this, and I think that was critical. The funding was critical, obviously, but the way that the grant was set up, where everything that we did was data driven, and it established this infrastructure of real time overdose data, was critical. Part of that, obviously that was August of 2019, and in the spring of 2020, the pandemic really hit us, right? So the things that we had planned to do on the grant were not able to be done. Like, we were doing face-to-face naloxone training in small groups at that time, where we would go out to a church or a community group, and we would do face-to-face naloxone training, healthcare professional to an individual. So when the pandemic hit, we couldn't do that anymore. Not only that, but that was when obviously fentanyl really hit and overdoses were spiking. Treatment and recovery resources had been really reduced because of lack of face-to-face, availability. So it was the perfect storm, as we described it at the time. So by December of 2020, our IT team at JCDH was able to stand up an online training system for naloxone, where anybody in the state of Alabama could go onto our website, and we worked within the existing law at the time to do this. And Alabama Department of Mental Health provided the naloxone for those outside of Jefferson County. We provided it for those inside Jefferson County, and Alabama Department of Public Health helped us with the shipping costs and the supply cost to get this out. So that program is still out there today. We went from distributing about, somewhere around 1,000 naloxone kits a year to 8,000, 10,000, it just really grew. And it was able to reach places in the state where there wasn't any other access while naloxone was still a prescription drug. In August of 2020, we stood up the OD2A task force, and so many people in this room were a part of that, and that became our monthly space to get all the partners together in a virtual space. We were able to share like what was going on, information about what was going on the ground, events that were coming up where people could get resources, but we were also able to share the hotspot data. So as we were sharing that hotspot data, our partners were constantly mobilizing, again, to those communities to get those resources out to those who needed it. And that group still meets monthly today. And as I mentioned, the online Narcan is still available today. Narcan did become over-the-counter, and obviously when that happened, it became much more accessible and many more people could distribute it. But cost remained a factor. It still remains a factor for many. So the Jefferson County Department of Health, ADMH, ADPH, they've maintained that free site so that cost is not an issue. Individuals anywhere in the state of Alabama can still get free Narcan on that site. And if you don't have a kit, this is my plug, to go out to that site and get a kit. You truly, can save a life. I would be remiss if I didn't just acknowledge all of the families that were willing to share their stories, the individuals that have been lost to this crisis. In the early days, those were what ultimately drove all of this action, which is helping so many people today. But also all of the partners. We had an amazing team at JCDH. Our team went to the police departments and trained all of their shifts. The Jefferson County Sheriff's Office allowed us to come train all of their deputies. The coroner's office, I've already mentioned, all of our community-based organizations. This was like, for me, the absolute peak of my career, to see so many people laser-focused and mission-aligned and 100% committed to turning this around. And, I'd never be able to name all the people that were involved, but just suffice it to say that it was truly a model of collaboration.
That's great. I know a lot of times you talk about the people who actually packed the naloxone and drove the naloxone to the post office. And
our mailroom, we had a mailroom clerk, and obviously she had her normal daily duties, and then each week she was processing 300 boxes of Narcan to get out, but she understood why she was doing that and what a difference it was making, and truly our whole team, and all of our partners took that same approach.
That's great. Representative Treadway, you touched on sort of that initial, when you were trying to move this legislation through, you touched on some stigma. Your experience in Montgomery and your experience in law enforcement, how did you address that then? And have you seen sort of attitudes towards people with opioid use disorder change over time?
It definitely has changed. Back then, though, the stigma, we had to get over those hurdles with PARCA's help, Dr. Wilson, others, getting me the data, getting it to the legislators, getting it to the senators, and educating folks was key. And having folks come down there with real life stories. Law enforcement officers have stood, I can't tell you how many have told me they've stood there when somebody has died, and only if they had that Narcan. And now they've got it all over the state, especially your rural areas. They didn't have that. And each one of those success stories has changed the way folks look at this issue and this problem. Not every story ends well. The friend I was speaking about in Mountain Brook, his son had a decades-long problem and overdosed on heroin this year. So didn't end well with him. But he is somebody that is very proud of this legislation. He's somebody who had it in his house. It just didn't work for him. But there's so many stories out there of success that has now changed the attitude towards addiction. And especially in law enforcement. Not only in law enforcement, I see legislation come before us in Montgomery, and you can just tell the attitude because of all the success stories that are out there.
That's great. Yeah, I've heard you say nothing bad has ever come from someone having Narcan.
That's right.
Yeah.
Nothing. And it's the stories, I've been there when they've expired, and it's like, I didn't know if you had something as simple. I don't know why it took so long, to be honest with you, Because when I started asking questions, I had to get educated on it. I just thought it was something the medics had when they showed up, but there's really no downside to it. You can use it on somebody if they're not in a respiratory failure dealing with opioids, it's not going to hurt them. And so it's like, that's how you sell it to folks that don't understand it. So there's really no downside here. Now, all the success stories, that stigma's gone.
Dr. Wilson, from the outset, you've seen the value of lived experience. So can you discuss how peers sort of influence the response, and then also your experience taking someone with lived experience down to Montgomery to discuss Narcan, but their sort of position when it comes to policy change or even harm reduction today?
Yeah, I consider it a real privilege to have gotten to know personally a lot of people in the recovery community. I don't have that lived experience myself, but these are very special people. A couple things. One is they have overcome amazing adversity and a malady that is extremely difficult to overcome. The other is that they have had to really come to grips with their own vulnerability and embrace humility, which is something all of us need to do. We'd all be better off if we did that every day. But it really did help inform the whole process, the whole response. As I mentioned before, it was a multi-tiered response with many different strategies, different groups of people meeting to discuss how do we solve this problem. And we had people with lived experience in the room in those meetings, either people who were recovering from addiction, people that had lost loved ones to addiction, or those that were in the treatment community. Because I was not the expert in the room. It was these other people that helped inform the process. So one story I will tell, it gets back to that naloxone bill. I don't know how many times I went down to Montgomery that year, 2015 legislative session. But that bill wasn't getting introduced in the committee in the House. That was the first or second step, I guess, to getting it passed. And I found out that it was because the committee chair thought that making naloxone available would encourage more drug use. We know that's not true, but at the time, a lot of people didn't know that was true. And, common sense would maybe think, well, that sort of makes sense. So one of my trips down there, I got a meeting with the chair of the committee, and I brought with me a person with lived experience who worked with the UAB recovery program of criminal justice. His name is Ralph Hendricks. Colorful character, but he had a lot of expertise and was very well versed with the whole world of addiction and interaction with the criminal justice system. So Ralph went down to that meeting with the chair of the committee, and he said, the last thing a person who's addicted to opioids wants is for somebody to give them naloxone, because it will put them into withdrawal, and it'll make them miserable. And a lot of times when people come out of an overdose, they're mad, they're angry, they're upset because you just ruined it for them, even though they might have been about to die. So that turned a switch, and it got introduced in the committee. We then had mothers come down who had children with addiction speak to the committee, show pictures. So all that to say that bringing down the people that had the real experience is what enabled us to get that policy passed. If I may talk about one other example, it was the development of the idea and establishment of the Recovery Resource Center, where John works now. One of the groups that we had that was meeting as part of that overall strategic plan was the Access to Treatment group. There was some treatment available, not nearly enough. Some of it was government-sponsored treatment, by the Department of Mental Health. Some of it was private treatment where you had to have health insurance or money to get treatment. Some of it was evidence-based treatment. Some of it was not. So one thing that we realized as a group, again, people with lived experience informing us, was that if you were addicted to drugs and you needed help, it was very hard to navigate the system. It was very hard to know where to turn. You might show up at one program and they say, well, you don't qualify. We treat women only. Or you show up at another one, it's like, well, you don't have insurance. You have to have money or insurance. So you go to a lot of doors that are closed. And finally, you find an open door maybe, and it may not be one of those evidence-based programs. It's not right for you, and the consequences could be deadly. That, you might go through detox, and then you go out, and you use again, and you die. So one of our mantras was no wrong door. We would establish a program where if you showed up there, it was the right door. And that was the Recovery Resource Center concept. It's a free service. You show up there, you're greeted by peer support specialists, people who have been there before, know what you're going through. You get a formal mental health approved assessment, which you need in order to get into one of these evidence-based programs. And then they help you, they make a referral based on your situation, what's best for you, what your insurance status is, where you live, et cetera, your own preferences. And then those peer support specialists support you along the way as you get referred, get into treatment, and on your way to recovery. So it was all informed by people with that lived experience. I was able to go to our Board of Health at the Health Department to get approval to fully fund the beginning of the recovery resource with 4 staff, including 2 peer support specialists. It started in early 2018, and then federal money started coming. And I don't know, how many do you have now working for you, John?
22.
Yeah. And what's your geographic footprint?
The entire state.
Yeah. So, yeah.
Thank you. I was going to ask for a brief sort of closing. There's a word in the nonprofit world.
We're going to take some audience questions.
Okay, great.
Back for you before you close.
Perfect.
So I think we will have some folks with microphones in the room. So if you was one on both sides, so if you would like to ask a question of our panel, just raise your hand or otherwise identify yourselves, and a microphone will come to you. Any questions at all? You all have thoroughly educated the audience. We have a question right down front.
I'm loud, I don't have a microphone, but I'm curious, personally and professionally, what role medication-assisted recovery has played, because I know there were a lot of really positive legislative changes as far as no longer needing a waiver X, things like that. So I was just curious what role, because I feel like there's a lot of stigma that's still associated with that.
John, can you repeat that real quick?
Yes, so Ms. Melissa Beck was asking about medication-assisted treatment and medications for opioid use disorder. There has been a lot of movement in the last, I would say, 4 to 5 years. A big pro was eliminating the X waiver, which a physician had to acquire in order to prescribe. But I think Dr. Travenstedt or Dr. Wilson.
Yeah, I can comment on that too. Yeah, now any doctor who gets a DEA license now has to do a certain amount of training in substance use, and then they all automatically get the ability to prescribe medicine to treat opioid dependence. We're talking about Suboxone or buprenorphine that you've probably heard of. Let me just comment on it a little bit in terms of that process that you're asking about where the stigma got removed. I remember multiple conversations with people in the community about, again, it was sort of like the Narcan story. Doesn't this promote more drug use? Isn't this replacing one addiction with another? Those were the quotes you heard. So opioid addiction, heroin, all these prescription painkillers, it's a physical dependence. And as Dr. Travenstedt mentioned, if you detox from it or suddenly quit, you will go into withdrawal. It makes you feel like you are going to die. It is terrible. And so people that are using heroin or using fentanyl get to the point where they're not using it just to get high. They're using it to avoid feeling like they're going to die every day. So eventually, and so the medicines are to replace that in a safe way. Methadone treatment programs are another example. They're highly effective. We don't have enough of them. But this is a way to keep people safe, and people on these medicines may eventually come off of them, but they may stay on them for life, and that's okay because they have families, they're being good parents, they're keeping down a job, etc. But I will say multiple conversations occurred. I mentioned earlier some of these non-evidence-based programs where they didn't believe in this. I remember being in a conversation with one of the community programs that did not believe in it. And they eventually said to other people in the room that were in the prescriber, like the prescribing these drugs group, and they said, we're tired of seeing our clients die. Can you help us? And that was a switch that I remember turning on among our partners in the community where most everybody got on board with this concept of medication-assisted treatment.
Thank you.
All for all the work you've done. This is truly impressive. As a clinician, and I know many of you, a lot of what I'm seeing now is opioids and stimulants, specifically methamphetamines. And I'm wondering what we could as a state be doing now so that in 10 years we're not in this room talking about missed opportunities to treat both the methamphetamine or other substances. I know, John, you mentioned multiple substance use. What should we be doing now to prevent some of these adverse consequences that we're anticipating?
Yeah, that's a tough one. Stimulant use, part of what we saw in Jefferson County when our overdoses peaked was fentanyl infiltration into our methamphetamine and our cocaine supply. And it required us to really change how we thought about things, and it also required to change how we reached out to the community, because it was a different community that was being impacted by the stimulant supply infiltration by fentanyl than the traditional opioid use disorder individuals. So, yeah, Dr. Eaton, I don't have, a magic answer to that. I would just say that public awareness of the safety or lack of safety of the drug supply is huge. Right now we have fentanyl test strips, but we have xylazine infiltration, we have additional novel substances that are entering our drug supply. And at this time, that we are only able to legally test for fentanyl with fentanyl test strips. When the drug paraphernalia law was modified to allow that, it was very specific modification. So there are other testing supplies, xylazine test strips, for example, other ways to test the drug supply that are currently not legal in Alabama. So I would say, public awareness and then consideration to more, drug testing for safety.
Probably have time for one more question.
Thank you for what you're doing is just marvelous. A question for the panel having to do with funding from the state and other sources. Is it adequate to the purposes to which you're engaged?
Dollars are always scarce in Montgomery, so we're going through the budgetary process now. The pie is only so big. But when issues arise like this and others, and folks like what you do here in this room and getting this information out and getting it to legislators and bringing about the awareness, you see that piece gets cut a little bit bigger for organizations that need to address these type of issues. So, you go back a decade or so ago compared to today, there's a much greater awareness from legislators and policymakers about addressing these issues before they get out of hand than kicking it down the road. But dollars are scarce. Everybody's wanting a piece of that pie.
Yeah, I would just add, we haven't talked about the opioid settlement dollars, but those are out there now. And so obviously that is overseen by our legislature and administered much of that by the Alabama Department of Mental Health. So we're grateful to have that funding, but it's short term. It will go away in a decade or so. And what I fear with funding is the pendulum swing. Like, right, okay, we've put all this funding towards this problem, and now things are better. So now we can redirect that funding to the next problem, right? But if we take our foot off the gas as it relates to this, we will see it cycle back through. And so I think if you are in a space to advocate for, for public funding for this specific problem, we just can't take our foot off the gas.
And addiction will always be with us. If it's not this, it'll be something else. So we need to maintain that infrastructure forever.
So thank you for that question. That was actually going to touch on my closing remarks. I was going to talk about the word sustainability, and not necessarily from a financial standpoint. But in closing, what do the three of you think needs to happen in order to sustain the momentum that we have right now with all of this work that we're going to hear more about today? How do we make sure that this continues?
I think a lot of the success that we had in this story you just heard was collaboration with partners. Public entities like the Department of Public Health and Department of Mental Health, collaborating with the nonprofits, collaborating with, again, like we said, the people who are affected by this. As Dr. Eaton brought up, we're facing a lot of other challenges in this area that we don't have answers to. When she asked that question about stimulants, I'm sitting here thinking, I don't know. But I think that continued collaboration and talking with each other, convening people to problem solve is really important.
Yeah, when those dollars are, it's important to keep the awareness up, keep the information flowing, what you're doing, what's successful. And, we meet in Montgomery 4 months a year. It's key that you go into there, when we go into that session, that we have this information, and so that that funding can be sustained.
Yeah, and I just continue to encourage, the phrase, nothing about us without us, critical to our success story that we're talking about today, were those families that were willing to share their stories, the people that were working on the front lines very early in this crisis that were willing to raise the alarms and, to inform those of us that didn't know what was going on of what was going on. And their voices have remained centered with the Jefferson County work. Much of, as we said, was started by Dr. Wilson in the way he involved people with lived experience. So no matter what public policy subject we're talking about, those of us that are in leadership positions or decision makers, we have to have those voices of the people that are either on the front lines working directly with these individuals or that are directly affected by whatever public policy topic we're talking about. And so, I think that's my parting thought.
Thank you all. This has been wonderful, and thank you for everything you're doing.